Hello everyone, in this video I'll be discussing general pharma, certain MCQs, and we have posted this in our telegram group. So myself Dr. BHARATH Kumar V D. So we'll discuss general pharma in this video. So the first question what we are going to take up in general pharma is choose the incorrect statement regarding drug absorption. So remember, when you read the question carefully, whether it is the false statement or right statement what they are asking, please evaluate that. First pass metabolism reduces viability. It's a true statement. Remember, viability and first pass are inversely proportional. And IV route has 100% viability, and absorption is directly proportional to viability. That means more absorption, more is bioavailable. The next one is highly ionized molecules are absorbed from stomach. It's a false statement. Remember, if they are highly ionized, it's very difficult to absorb. If they are highly water soluble, also the same problem. Only if they are highly lipid soluble, it can be easily absorbed. Heparin not absorbed due to its large size. That's a true statement. That is why heparin is not given orally, and it is not going to cross the placenta, so it is safe in pregnant women. So that is also true. Most common method of drug absorption is by simple diffusion. That's a true statement. That means the drug moves from high concentration to low concentration. So here the answer will be B. Highly ionized molecules are absorbed from stomach is a false statement. Moving on to the next question, which is the best way to manage a patient with aspirin poisoning? Now, whenever I talk about poisoning, I want you all to make a list of poison and antidote, because every exam it comes. Now, aspirin poisoning, there is no antidote. That means I should do dialysis or I should change the pH of the urine. Now, aspirin is an acidic drug. To make it water soluble or ionized, I should make the urine alkaline by using sodium bicarbonate. So A is the right answer. Now, make urine acidic by ammonium chloride, that is required for basic drug poisoning like amphetamine. Treat with N-acetylcysteine is required for paracetamol overdose, not for aspirin overdose. Treat with paracetamol. Only we treat with paracetamol in aspirin if aspirin is causing hyperthermia. So the answer will be A. Now coming back to the next question, which of the following is true about highly plasma protein bound drug? Now what do you mean by highly plasma protein bound drug? Let me take the example of diazepam. It is 90% plasma protein bound. That means if I give 100 drugs, 90 are bound and only 10% are free. Now if the drug is highly plasma protein bound, can it get filtered easily from the kidneys or the glomerulus? No. So the filtration decreases, so there will be decreased GFR. This is the true statement. A. True. Now increased tubular secretion. Remember, secretion doesn't depend on the plasma protein binding. And high volume of distribution, also false. Remember, if a drug is having high plasma protein binding, 90% for example is plasma protein bound, that means they stay in the blood vessel, they have low volume of distribution, so that is also false. Cannot be easily removed by dialysis. Remember, this is also a true statement. So there are two right answers in this questions: decreased GFR and cannot be removed by dialysis easily, because if a drug is highly plasma protein bound, only 10% can be filtered, 90% is not able to be filtered in the dialysis. So dialysis is not useful in this. So both are correct answer if you have written that. A female patient is suffering from tuberculosis, comes to you with OCP failure history. Which of the following drug might be responsible for this? Isoniazid, ethambutol, rifampicin, streptomycin. 100%. Remember, rifampicin is an enzyme inducer which will increase the number of enzymes and metabolize the drugs faster, and that will lead to decreased levels of the drug. And if it is OCP, they will be contraceptive failure and she may become pregnant. So this is a repeatedly asked question. And also remember, if she is on oral contraceptive pill and she has been diagnosed TB, tell her to use alternative method of contraception. So this is a repeatedly asked drug interaction, and I want you to remember from this video the list of enzyme inducer and inhibitors which I have given in the notes. Now coming to the kinetics of elimination, false about first order kinetics. Now false we have to find out, not the true one, false. Now remember, constant fraction of drug is eliminated in unit time. It's a true one. Remember, first order, the fraction is constant. half-life is also constant, clearance is also constant, but elimination rate is not constant. Elimination rate is directly proportional to plasma concentration. Now whenever you read first order, compare that with zero order. Zero order. Now first of all, let us write what is constant in zero order. The amount going out is constant and the elimination rate is constant. So the amount going out is constant and elimination rate is constant, but the half-life and clearance are variable. They are not the same. So that is the difference between first order and zero order kinetics. Now moving on to another drug. A drug Z has affinity and intrinsic activity of 0.8, then it is what? Now agonist, partial agonist, inverse agonist, all of them have affinity. But how do I tell they are agonist? If they are producing +1, that is maximum response. If the response is between 0 to 1, then they are partial agonist. So here it is 0.8, the answer will be B. Number C, inverse agonist, the response is -1, that means opposite action. And antagonist, the response is 0. So the answer will be here partial agonist because it is 0.8. So 0.8 means submaximal response. Coming to the next one, which of the following receptor is G protein couple receptor? Now nicotinic receptor is not G protein couple receptor. Remember, nicotinic and GABA A are ion channel receptor. So can we revise other ion channel receptors? Yes, the 5-HT3, then glycine, glutamate are ion channel receptor. Now muscarinic receptor are the G protein couple receptor. The insulin receptor belongs to tyrosine kinase. Remember, the growth factors, insulin receptor and insulin-like growth factor, all of them belong to tyrosine kinase. Now who belongs to JAK-STAT? JAK-STAT, it is mainly the cytokines, interleukins and growth hormone and prolactin. So if you remember them, the remaining receptor are all GPCR. So if you remember them, the remaining all are GPCR. And also I want you to remember the nuclear receptors like vitamin A, vitamin D, thyroxine, PPR, then the steroids and sex steroids. Now elevation of glucose by corticosteroids is counteracted by insulin is an example of. Remember, corticosteroids act through the nuclear receptor and they increase the glucose. Insulin acts through tyrosine kinase receptor and decrease the glucose. Remember, if the receptors are different and actions are opposite, then we call them as physiological antagonism. Another example is the adrenaline and histamine. They are also physiological. Chemical antagonism is not the answer. The answer is physiological antagonism. So chemical means there should be some chemical reaction and antagonism. For example, the antacids neutralizing HCl, the chelating agents. Competitive antagonism means both the agonist and antagonist bind to the same site and you can overcome this antagonism. And the dose response curve shift rightwards and parallel, that is competitive antagonism. Non-competitive antagonism, the agonist antagonist, they don't bind to the same site and the antagonism curve will not shift and it will become flat. That's it. So this is the point here. Now again, the clinical trials is tested here. Which of the phase of clinical trial is carried out after a new drug is marketed? Now after marketed, that means after getting market license, the phase that is done is called phase 4. Phase 4 is also called as post-marketing surveillance to check for rare adverse effect, to check drug interaction, to check what happens in pregnant, lactation and in elderly people. The major aim of phase 1 is to check safety, to check maximum tolerated dose and pharmacokinetics, and human healthy volunteers are involved. Now phase 2 is the place where we check the efficacy for the first time. So once efficacy is confirmed, then I will check the dose ranging. So we will confirm efficacy more in phase 3. So phase 3 is the one where we confirm the efficacy, phase 3. And remember how to differentiate phase 2 and phase 3. Phase 1, 2 is done in 1 or 2 centers, but phase 3 is done in multiple centers. So don't take into consideration number of patients, take into consideration number of centers, multiple centers, efficacy and patients, then phase 3. 1 or 2 center patients are involved, you have to check efficacy, then phase 2. And remember, maximum drug failure occurs in phase 2. Now phase 0 is also called as microdosing trial. Usually it is not done, but the major aim is to check for pharmacokinetics. Most of the students got confused with this. Which of the following schedule covers prescription by a registered medical practitioner and given in duplicate? Now that is called Schedule X. Now remember X for Xerox. The drug is given as Xerox because these are highly psychotropic drugs like ketamine. If you want to prescribe ketamine, you have to give the prescription in duplicate, and one is kept by the pharmacist and one by the patient. Now Schedule S is the normal schedule where the drugs are prescribed by the registered medical practitioner. Since they have given duplicates, so the answer will be Schedule X. Category X is nothing but that's a category for teratogenic risk, and Schedule P will give the storage condition of the drug. So I hope these are the questions which we had in discussion of Telegram. I hope you understood this. So if you like the video, please put your comments here and let me know anything improvement we can do with this, and best wishes for your exams, and share to your friends. Thank you all.